Welcome to the Emergency Airways lecture. So in this series, we're going to go over different types of ways to establish a patent airway. So we'll go over some techniques, and then hopefully we'll be able to practice these in lab as well. So let's get started. When we're looking at airway management techniques, we need to look at, first of all, looking at the patient and trying to make sure that we provide them with what they need. Not with what we want them to have, but what they need. Does the patient lack the ability to maintain a patent airway? Does the patient lack the ability to protect their airway? Does the patient lack the ability to have proper ventilation but still can protect their airway, right? Is the patient semi-conscious? Is the patient fully unconscious? Is the patient fully aware? So we need to look at what type of airway tools and techniques we're going to have. So one of the most critical things you can look at here is looking at what the patient actually needs. So making sure that you're not overdoing it. So if the patient's semi-conscious and you put an oropharyngeal airway in, you could cause the patient to gag and vomit. Obviously that could lead to aspiration, and aspiration could then lead to ARDS. So we need to look at making sure we give them with what they need. When a patient that's semi-conscious might just need something like a nasal pharyngeal airway or the nasal trumpet. So we need to look at this, and this will require some critical thinking skills when we're trying to find out what the patient needs overall. This looks at what's the mechanics of going on with their airway right now, and we need to look at that more in depth. So the most important part of managing the airway overall is to determine the difficulty of it. So I would highlight that part. How difficult is this airway? Do they have a short neck? Do they have a swollen neck? I had a hang victim a couple of times come in, and their airway was so swollen to intubate them from up top was very, very difficult to go through the oropharynx and go in and intubate. One of those hang victims, we had to go ahead and use a bronchoscope to intubate with as an intubation tool. So looking at the difficulty of the airway is going to help us when we're determining what type of personnel we're going to have in the room, what type of equipment we want available on hand and not just 2 rooms over or down the hall, right? We want to know how difficult this airway is and if we have the appropriate equipment for it, because you don't want to go into a situation when you had the option of knowing how difficult it was without the proper tools needed to manage that airway, right? We want a safe patient experience. It's like a pilot taking off in an airplane. They're going to do their pre-checks. They're going to go through all the different systems, make sure everything's functioning appropriately. And they're just going to make sure that they're prepared for any type of situation. They're going to look at the weather patterns, and it's the same for us. We're going to look at, hey, how difficult is this airway? Is there things I can do to help assess how difficult an airway is, and make sure we have the appropriate staff and the appropriate equipment available to have a smooth flight, to have a smooth intubation, right? And that's what we're going to be doing here. When you have everything available, when you know the situation ahead of you, you're going to be a lot more prepared. You're going to be more calm. You're going to have that calm confidence going into it, and then we'll all have a plan knowing who's doing what in this difficult intubation and where the equipment is and who's comfortable using that equipment, right? So this is all you having solid preparation skills, staying focused, and having the right tools and right decisions ahead of you. So hopefully this will help you make some of those tools when you have a situation like you see on the left down here where this young fellow was a victim. It's going to be a bit of a difficult situation at first, but you need to plan, prepare, communicate, right? If he's still breathing, if he has a patent airway, all that stuff still going on, we will communicate and we'll try to figure out what's the best alternative airway if he needs one, what alternative airway we would use, right? Same thing with this other patient down here with something lodged in his trachea. That's something that we want to look at and just figure out, okay, if we had to ventilate him, if he was still breathing and everything like that, what are we going to do? Are we going to intubate him from up top and go past the stab wound? Would we go ahead with a tracheostomy? Would he be a cricothyrotomy if for some reason the swelling got too bad and we couldn't establish an airway? So So these are all things we need to communicate with the care team about, and this is going to require you sort of being that focused, prepared person that knows the right tools and can help make the right decisions. So determining the difficulty of the airway is the most important part of managing the airway. So I would remember that. So when we're looking at the upper airway, this should be sort of a flashback to pulmonary anatomy and physiology. The big functions of the upper airway include warm, filter, heat, humidify, right? Or filter, protect, heat, humidify. When we're looking at this, we need the nose and oral pharynx to filter. We need it to filter all that bad stuff that's going in. So whenever the upper airway is compromised or whenever it's bypassed, it's not doing those functions. It's not filtering, protecting, heating, and humidifying. It's not doing any of those functions. So we need it to be able to have those functions. So when we bypass it, we need to have something function as the nose. That means we need to filter the air, we need to warm the air, humidify it as well, and then make sure that we're doing everything we can till their body has those functions back, till the upper airway has those functions back. So it's also going to be important, especially when we get into intubation and alternate airways. Knowing your anatomy is going to be crucial. Because when we look at something like the king tube down here, and that's why I sort of named the presentation the way I did, the king tube purposely gets inserted into the esophageal opening. And when you look at something like a double lumen ET tube, that's going to be purposely put into the trachea. And in fact, it goes deeper into the trachea, and it goes, one side will go into a side of the main stem and the other one won't. And then when we're looking at something like an LMA, that just goes to the entrance or the top part and covers up the esophagus. So therefore, every ventilation will go through their trachea, right? So it's blocking the esophagus and allowing it to go to the trachea. When you look at a combi tube, that can go in either the trachea or the esophagus. And then when we're looking at different ways to intubate a patient or to place a tracheostomy tube, there's oral intubation, which is obviously preferred. There's still nasal intubation as well. And then we get into issues, is the patient on blood thinners? If we do a nasal intubation, could it cause a significant amount of bleeding that could compromise the integrity of the airway more than it already is? Is the risk worth the benefit of a procedure like that? So when we're looking at this, or do they have a sinus infection? Are we looking at spreading an upper airway infection to the lower airway, right? So there's so many different parts in here. Trauma victims, do they have a deviated septum? So this is all you knowing the anatomy and looking at what's best for the patient. Let's say a patient is a C-spine injury or in C-spine precautions. You might have to do something like a retrograde intubation, and there's a video clip somewhere in either this presentation or the intubation presentation about that. So knowing your anatomy is going to be crucial for managing and evaluating the difficulty of the airway. Right, so make sure you understand the cavities, the components. So remember, the pharynx are the posterior part of these things. So when we're looking at that, and I love this picture here because it shows the nasopharynx, remember, is the posterior part of it. The anterior part has a different type of cell. Back here we're looking at pseudostratified, stratified squamous, and then back to stratified squamous here, and then pseudostratified ciliated columnar back down here. So hopefully those are throwbacks from back in pulmonary A&P, but when we're looking at this, we need to look at all the components that go on. If we're looking at putting in a nasal trumpet, we need to make sure that we put in the nasal trumpet as low as we can when we're doing this, below the inferior concha, right? The meatus, if you will. So we need to put it as low as possible because there's the most space in that area. And when we put that nasal trumpet in, make sure it's lubricated. Make sure, I always put a little bit of saline in there before I put the lubricated nasal trumpet in there too, just to help moisten and loosen everything up, so that way it wouldn't tear at any tissue as I was inserting the nasal trumpet. So different things like that. And then there's different sizes of nasal trumpets, and we'll get into how to measure that. Because if you put in a nasal airway and it goes too shallow, let's say it terminates here right behind the uvula, well, it's not going to do anything to keep the tongue from being flopping against the posterior part of the oral pharynx. It's not going to help keep a patent airway. So if you have too shallow of a nasal trumpet or a nasal airway, it's not going to be helpful or beneficial. If you have too long of one, it could actually push itself and curl, or it could even go to the entrance of the esophagus. It could go curl into the oral pharynx as well. So it may not be effective as well. So we're going to get into how to look at the appropriate size equipment for this patient, but it's you also knowing the anatomy and what you're trying to displace and why. So when we're looking at this on an adult, the tongue is usually the most common airway obstruction, right? On an adult, the tongue is usually the most common airway obstruction. And so one of our big goals usually is to do like a jaw thrust or head tilt chin lift, or put in something that maintains the patency of that airway. So this is a good picture to sort of look at and have a visualization from that side view of what can we do to sort of keep the tongue and everything from the collapsing back on the oral pharynx. So even in conscious sedations, we're putting someone's shoulder back in place or anything like that, where we put them under deep sedation, their tongue can still flop to the back of their airway. And in fact, almost every case I was involved in with conscious sedations, there would be some level where the patient would be ultra relaxed and they would start snoring, so to speak, and their end tidal CO2 would start to go down because they're not ventilating as well. So I would just do a jaw thrust for those patients. And that jaw thrust, most of the time, was just enough to bring that tongue up off the posterior section of the oral pharynx to allow for them to ventilate appropriately. So I didn't have to put in a nasal trumpet and have them wake up with something stuck deep inside their nose. I didn't have to put in an oral airway if they were semi-conscious. It's not a good idea anyway because they could throw up. Most of these patients have eaten recently when they show up to the emergency department, especially if they've had something where their shoulder just came out of place or something like that for a conscious sedation. So when we're looking at this, we need to make sure that we're doing what we can to get that tongue as away from that posterior section of the oral pharynx as we can. And then we could also use mechanical means, things like CPAP and things like that help stent open the airway. As well, as you know from sleep medicine, where we use CPAP as a form of stenting, right? Pushing it open. So there's different ways to do this, and that's what we're going to be looking at here, is alternate ways to make sure that their pharynx, everything is communicating appropriately with each other to help maintain ventilation, which then should help maintain oxygenation as well. So the larynx, between the base of the tongue and the upper end of the trachea, those are the borders. The function of the larynx is a passageway of gas into the trachea. It also has a big role in protecting them from aspirating, and that's a big deal because if someone loses their ability to cough, if someone loses their ability to gag, that pharyngeal reflex, if they lose that, then their ability to protect their lungs from vomit, from foreign material, is impeded significantly and could be one of the indications for intubation. Their inability to protect their airway could be an indication to intubate someone. Now, it's sort of a gray area. We might have patients where they might elect, let's just say they're under a lot of narcotics, and instead of going ahead and intubating them right away because they can't protect their trachea, we might just elect to reverse the narcotic or whatever's causing their situation, and that would then restore their ability to protect the airway, and then we would avoid intubation and ventilation and all that stuff altogether. So understand there's a little bit of gray area, even though it's a set in stone thing that, hey, if they can't protect the airway, we're going to intubate. But if we can do something like help them ventilate more efficiently to get their CO2 level down, and then they return to a more conscious level, then we avoid intubation and we avoid all that other stuff. So understand there will be some gray area here, and that's okay. It's okay to have that little bit of gray area, but when we're looking at this, I want you to understand that it's important that your body has the ability to protect from aspiration. If we can readily reverse it, we will before we do mechanical ventilation, right? If it was you and you had the option of avoiding mechanical ventilation over with just a short procedure, or going through a long maybe 8 to 24 hours of mechanical ventilation, you're going to pick the short procedure every time. And same thing, the risks and benefits just aren't there to go ahead and intubate no matter what. Okay, it depends if there's other things going on. Let's say their heart rate's super fast, their blood pressure's low or super high, right? Things like that could also be going on, and then that failure to protect airway plus high CO2 plus so on and so forth may lead us to mechanical ventilation and intubation. But we just got to understand there's a little bit of area here that you're going to have to adjust. If we can readily reverse it and do it safely while their airway's somewhat intact, then we will. Right, so the function, protect from aspiration, and then speech, phonation. And even after we extubate a patient, one of the first things I would have them do, if they could, is to say their name or something like that. Now, kids, they'll start talking as soon as possible, or crying, so on and so forth. But when we're looking at adults, that's one of the things I would always chart on. After we extubated a patient, I would chart patient was able to phonate, or patient with a hoarse voice, or so on and so forth. It's important to know if that function is sort of restored or not, especially if they do have laryngeal problems. Let's say they have a paralyzed vocal cord or something like that. They have to deal with their swollen throat. I want to know if their throat is swollen, and one of the ways that you can tell is sort of that scratchiness of their voice, or how hoarse their voice is. And that's going to be something that you'll have to develop over time, and that's a subjective assessment, but it's something that I thought was a good way just to make sure that they're able to actually speak okay. Their voice wasn't just a whisper and barely moving air. Right, you're still going to check for stridor, you're still going to look at other metrics as well after you extubate a patient, but that was just one of the metrics that I would use amongst many for my total patient assessment. So remember, there are 9 cartilages. There are 3 singled paired, 3 singled and 3 pairs, which should be 9 total, because 3 paired would be 2, 4, 6, 8, right? 2, 4, 6, and then 7, 8, 9 for your 3 singled. When we're looking at this, your 3 single cartilages are your epiglottis. This is the epiglottis here. That's important because it routes food and liquids hopefully to the esophagus and opens up for us to breathe naturally. This is also the big thing to get out of the way on adults besides the tongue. The tongue is the reason why we use a lot of MAC blades in intubation. The MAC blade helps directly displace the tongue. The tongue is usually the hard part for a lot of people, and so the MAC blade, when we're looking at the MAC versus Miller blade for intubation, the MAC blade is going to be a lot more beneficial for directly displacing the tongue. Now remember, the tip of the MAC blade goes into the vallicula, but it directly scoops and moves the tongue out of the way. So, and we'll do some intubation practices in lab and get you guys ready to sort of feel the differences between a MAC and Miller and why you would want to use one versus the other. But in general, adults, we want to control the tongue, especially if they have a swollen airway, things like that. We want to control that tongue and move it out of the way, and that's why we're trying to do that. And then by doing this, remember, the epiglottis is displaced in both blade styles for intubation. The one's indirect, which is the MAC blade, goes into the vallicula and actually shortens this little tendon here. So the tip goes into that vallicula and shortens the tendon and pulls that epiglottis up, or anterior, or superior if the patient's laying supine. It puts tension on that tendon and puts the epiglottis superior, so you have an open view for intubation. Now, if you're doing a Miller blade, remember that directly displaces the epiglottis and you're pulling it out. Miller blade's great for giving you a good view, but it's not as handy for moving the tongue out of the way, which is usually a lot of the fight for getting a good view for a lot of patients. they have a very anterior airway, then go with the Miller blade. If they have a big tongue and all that stuff's going on, you have to displace a lot of material, then go ahead and use that Mac blade. And Mac blade, according to American Society of Anesthesia, as of recording this, is considered less traumatic for an adult because it's indirect displacement of the epiglottis, so there's no risk of injury to the epiglottis with a Mac blade as well. So in adult intubations, you'll probably see Mac blades over anything. So the epiglottis is important. Okay. The other single cartilage is your thyroid cartilage and your cricoid cartilage. Those are the big things. When we talk about doing cric pressure and all that stuff, that's where we're going to look at putting pressure on the cricoid cartilage, and you might see that. Some people might want it, some people might not. During intubation, if someone has a very anterior airway, in other words, we can't see the vocal cords for some reason or another, you can ask for cric pressure. It's also called a Selleck maneuver, like Tom Selleck, right? It's called a Selleck maneuver. So if you want to sound fancy during an intubation and they can't see the cords, hey, do you want a Selleck maneuver? Try not to be that person. Try to be like, hey, do you want some cric pressure, right? And that just pushes the cricoid posterior, which should allow for the vocal cords and all that stuff to become better in view for the intubator. So if you're at a hospital where the RT is intubating and you're intubating, you don't see the airway structures, maybe you ask for a cricoid pressure, right? Push it down a little bit, push it superior or inferior a little bit, so that way you can see the airway, and then there you go, you're ready to intubate. If you have to do a cricothyrotomy, if you can feel your throat right now, feel for your thyroid prominence, aka the Adam's apple, right? And then go right below it, between your cricoid and your thyroid cartilage. You can feel this on your throat right now. And in between the two, there's this cricothyroid membrane. And this is where we would put the cricotomy, where we put that little needle there, the little tendon in between, and you can feel it on yourself right now, right? If you feel that area in between the two. And that's where we would put that cricothyrotomy for an emergency airway. And then obviously we would do a trach. A tracheostomy is usually between the second and third tracheal rings down here. So it's lower, and there's a lot more space in these tracheal rings than there is in that cricothyroid membrane, so we can use a tracheostomy tube, a lot bigger volumen of airway, which according to Posey's law says we can ventilate a lot more efficiently and reduce airway resistance, right? So a lot less turbulence with a tracheostomy tube compared to a cricothyrotomy. So it's good to look at these. It's good to go back over all these airway structures, especially when we're doing a tracheostomy procedure, a bedside percutaneous tracheostomy procedure on a patient, compared to compared to an open trach, or even compared to a cricothyrotomy. You're going to want to know the anatomical differences and the why behind why would they pick a cricothyrotomy versus a tracheostomy. All right, so when we're looking into the lower airway, these are some of the structures that you're going to see. And so this sort of gives you that good view of the epiglottis being superior up here. And then you're going to have your cuneiform and corniculates inferior, right? Those are going to be inferior. They're going to be down here. And you can sort of see them down here. Your arytenoids attach back here. That's sort of the base of your back part of your airway, and so you're going to see the interior of the larynx, hopefully. Inferior of the larynx, hopefully. The idea is when you intubate, you need to see the vocal cords. You need to identify them, no matter how swollen they are. You need to see what you're doing. Now, there's blind intubation. There's alternate airways where we don't need to see the cords, like an LMA, a laryngeal mask airway, or a king tube or a combi tube. There's other ways to do it blindly. Even nasal intubation can be blind as well. In other words, we don't need to see the vocal cords. We'll use other techniques, but we need to be able to identify these structures, especially if you're using video intubation skills. One of the neat things about video intubations here is the doctors are usually going to point out these structures, and it's something, if you're able to, in our emergency department, we'd even let our pre-hospital, our paramedics, all those guys, they would have the opportunity to intubate as well besides the RT, so that way they could see the structures, and then the doctor could also guide them while they're looking at it on the screen. Everyone sees it on the screen. Everyone sees the tube go through the vocal cords. It's really neat, and it's actually going to help you, if you're at a facility that's very progressive with respiratory therapy, also be able to do more intubations and see a better structure support of the airway. So make sure you identify your landmarks. Make sure that if you're doing intubation, you're identifying and you see all your landmarks. So make sure you guys are familiar with all this stuff. Even when we're doing a bronchoscopy, when they go to the vocal cords, usually we'll drop 2% lidocaine on the vocal cords, right? So that's something that we do to help numb the vocal cords so they're not spasming or having any issues when we go down to the lower airway with that bronchoscope. The pediatric and adult differences, you need to pay attention to this. The smallest part of an airway for a pediatric patient and the smallest part of the airway for an adult, the smallest part of the airway for an adult is going to be the glottis. It's going to be that glottic opening, right? The cricoid cartilage, right? That area below the vocal cords, the area below the vocal cords. The area below the vocal cords is the smallest part of an airway for a kid, and we covered this in pulmonary A&P. Go figure that it would come into play later. Because of this, when we're intubating, it isn't going through the vocal cords that's the hardest part of intubating a neonate. It's actually going through using the right size tube to go through their cartilage inferior to their vocal cords. And that's also why you see neonate endotracheal tubes don't have a cuff on them. They don't have a balloon on the tip there, because if we use the right size ET tube, we're not going to have that cuff because their body has an anatomical cuff. So you need to know the difference between what's the smallest part of an airway for an adult, the glottic opening, and what's the smallest part of airway for a child. It is not the glottic opening, right? So there's going to be big differences here. So when we're looking at something like epiglottitis, when we're looking at croup or LTB, we're going to be looking at different things that could make it difficult to intubate. If a kid has LTB or croup, intubation is going to be difficult, right? And you're going to want someone very advanced. You might want video intubation equipment. This is where this all comes together. So I like this visualization just to sort of show you the difference. One of the adult intubations I did, not the last one, but one of the last adult intubations I did, I had just my previous intubations, like 5 or 6 previous intubations to that, was on neonates, right? Little kids, like pediatric neonates. And then I went downstairs to help an adult ICU therapist, and I went down there. And sure enough, like, they weren't able to sort of see the airway or vocal cords, and they were using the Mac blade. So I'm like, well, visualization, I'll try the Miller blade. And the Miller blade is what we use for pediatric patients because their airways are very anterior. And so I use the Miller blade, and I can see perfectly, like this view here that you see on the adult on the right. It was amazing. It was like, man, that's the biggest airway I have ever seen, like, in my, right? Because my comparison was over here, right? That was my baseline. And so for me, it was like a Mack truck highway type situation. It was like, okay, I can get a ET tube in there, right? So you're going to sort of see the difference between the two. But even adults, you might have adults, especially that have a swollen pharynx, that might have their airway so swollen, it might look over here on the left like a pediatric airway. We might have to downsize their ET tube, which is not something we like doing, but we might have to. When you're looking at this, this is just a good side view from a radiology standpoint. You can sort of see the tongue and the airway, and you can see the airway here. I'll try to highlight it there. And then just getting this epiglottis out of the way is going to be the big thing here. So if we can get the epiglottis out of the way, we can restore function into the trachea. So when we're looking at this, this is going to be a Mac blade that you see in here, right? And it's going to go in there, and it's going to try to put the vocal cords and move them out of the way so it's a lot easier for this baby to be, or this patient over here, to be intubated. So you can just sort of see the idea is to sort of just restore that patency back into that airway overall. All right, you do need to know these numbers. I will test you on them. The trachea starts at the cricoid and ends at the second costal cartilage. So that's the area behind the, remember this is a landmark. We also use the same landmark for EKGs. It's the angle of Louis, right? Or the sternal angle is the alternate term for it. So if we're going to NT suction someone, remember we measure from their nair to their tragus and from their tragus to the sternal angle, right? Or the angle of Louis. Or if we're looking at where someone's carina is when we're NT suctioning, we're going to measure that area, and then we're going to subtract like a centimeter or two, so that way we know we're not going to be stabbing the carina, right? No stabbing carinas. That causes vagals and all this other stuff to happen. The average adult airway is 11 to 13 centimeters long. We're talking about the trachea here, and about 1.5 to 2.5 centimeters in diameter. And then there's about 15 to 20 C-shaped rings. This is all stuff we've covered before, so hopefully your memory bank has them in like, oh yeah, I remember learning that at one point somewhere back there. You do need to remember this, and it just depends on the size of the adult, right? If you have someone that's 5'1", they might only have 15 C-shaped rings. If you have Shaquille O'Neal, he might have 20 C-shaped rings, right? So this is just going to be based upon the size of the adult more than anything, why there's that range of things. When we're looking at opening the airway, this is going to be crucial. And in fact, if you can stabilize an airway and let the patient ventilate on their own before you start jamming tubes and stuff in there, if they're able to breathe on their own and you're just able to take the obstruction of the tongue away from the equation, then you're going to allow for a lot safer intubation overall. So that's one of the key components, and that's one of the ways I knew someone was a good advanced practitioner or an RT, is instead of just grabbing the intubation tools and going for it, they would actually do what they could to stabilize the airway if the patient had spontaneous breathing, and allow for us to get the tools we need, and this will allow them to ventilate and oxygenate well before we have to intubate them. So if you can stabilize the airway, keep it patent while the patient is actually breathing on their own and optimize it, then we're going to do that. So one of your big techniques is going to actually be doing something like a jaw thrust or head tilt chin lift with bagging, with hand ventilating the patient, and that's going to help get the patient's ventilation on board, as well as their oxygenation on board, so that way during the intubation procedure their ventilation and oxygenations will be stable for that procedure. That's a best scenario. So we need to make sure if we can pre-ventilate and pre-oxygenate a patient safely that we do so, right? But it's got to be done safely. As I say all these things, make sure you know the policy and procedure of each facility you work at. Some hospitals may not want you to hand ventilate a patient that doesn't have an artificial airway, and there are structures behind that may think that you might back pressure gastric contents and cause aspiration, right? So just be aware of each facility's situations, and then you should be aware of that. When's the last time this patient had anything to eat? Are they NPO, nothing by mouth, right? This is something you should understand. The last adult intubation I did, I asked the nurse in that intubation, when's the last time this patient had anything to eat? She's like, oh, she didn't have anything for the past 9 hours, no coffee or anything, no food. And so I felt more confident pre-ventilating with hand bagging than if she had just eaten breakfast, right? Things like that will come into play, and that's where you get to use your critical thinking skills. So the most common cause, back to the program, most common cause of airway obstruction is going to be the tongue, right? The tongue falling against the back part of the pharynx. And if we can get that out of the way in an adult, that's going to be a big help. So this is usually because they lose muscle tone. in their airway. Stroke victims have this happen, but most adults will have this happen when they lose that muscle tone. Their tongue's going to fall to the back of their throat. No matter how hard of a handbag you push, squeeze that bag, no matter how much CPAP you give that patient at that point, it may not be enough to overcome the complete loss of that muscle structure back there. So when we're looking at this, you might have to use either an alternate airway, like a nasal or oral airway, or you might have to do EC or head tilt chin lift or jaw thrust if they're a suspected spinal cord injury patient. So this is what we got to look at here. So this is where we looked at the head tilt. So this is where we go from this position here to this position here. We're moving them back into a sniffing or head tilt position. That takes that tongue that's on the back part of the airway and then moves it anterior. It gets it open, so we have a lot more patency. And if this patient has spontaneous breathing still, which a lot of patients you will see will still have some spontaneous breathing, right? If we haven't pushed paralytics or anything, that's going to help that patient ultimately ventilate, pre-oxygenate, and pre-ventilate before we intubate. So that's going to be a big bonus. And sometimes you'll see if you open that airway up and you start ventilating them, hand ventilating them, you might see some of these patients actually start to come around because their issue was something that was readily fixable, but their CO2 levels got a little too high. Right? So do whatever you can to get the tongue from the back part of the airway, and we need to be aware of different circumstances, like, do we use positive pressure if their stomach's full? Do we use a nasal pharyngeal airway, right, to get the tongue? Because the nasal pharyngeal airway goes down here and then behind the tongue and then to the entrance behind the tongue, so that way it allows gas to bypass that. Well, if the patient's semi-conscious, perfect. If the patient's fully unconscious, not so perfect. If the patient's fully unconscious, then we can use an oropharyngeal airway to keep their airway open while we ventilate or oxygenate. Do we do a head tilt if they have suspected spinal cord injury? Absolutely not. Right? That could be detrimental to their C-spine. Right? And so then you might have to do something like a jaw thrust. So when we're looking at this, your two options for just opening the airway, and yes, I love this picture here, is to do a head tilt chin lift. And this is done when there's no spinal cord injury or C-spine precautions involved. And that's a big thing to understand if you're working emergency medicine, if you're working critical care. Is this patient a C-spine or spinal cord injury patient? If there is, then be safe and just use the jaw thrust. And my benefit, unless we were actively bagging a patient or anything like that, I would just use the jaw thrust almost every time. And in fact, if you're doing a good EC technique, a jaw thrust is what you're using as well when you're doing this. So just be gentle. If they've had a spinal fusion in the past, if they've had C-spine problems, then you're obviously not going to want to do the chin lift, the head tilt chin lift. You're just going to want to do the jaw thrust. So when in doubt, I would always just go ahead and do the jaw thrust, and you can use your discretion on this, but just make sure that you are checking with the care team. Is there patient have a history of C-spine injury or current C-spine injury, right? That's what I would make sure. So the head tilt chin lift, we're going to tilt the head back, open up the airway. The jaw thrust is where you put your hands underneath the mandible there, the back part right below the chin, and you just pull up, like you push up, sort of like I wanted to put a Bubba Gump. Do you guys remember Bubba Gump from the Forest? No, maybe not. And it just sort of pushes the lower part of the jaw anterior. It pushes it out of the way. So that way it's sort of that low jaw coming out. That helps move the tongue anterior and allows for patency of the airway. Like I said, most of my conscious sedation patients, I never had to put a nasal trumpet in my conscious sedation patients because all I would do is just the jaw thrust. Most of them still had breathing. A couple of them I had to bag while I was doing the jaw thrust, right? Do the EC technique, but most of the time, just that jaw thrust was enough to keep that tongue out of the way until the drug started wearing off. So make sure you understand the difference between the two and when you would use a jaw thrust versus a head tilt chin lift. Oropharyngeal airways, these are very crucial, especially if you're trying to pre-ventilate a patient for intubation. Usually we'll put an oropharyngeal airway in to help our bagging be more efficient, because that keeps the tongue out of the back part of the oropharynx. So there are, make sure you measure it. You're going to do the mouth to the mandible, like you see in this picture down here, to the angle of the mandible there. If it's too long, you don't want to use it because it can actually go deep and impede the ability to ventilate. It can actually block their airway. If it's too short, it's not going to keep the tongue off the back of the throat. So you need to make sure it's just right, and this is how you manage it. This is how you measure it, so that way you put the right size of oral airway. And we even have these for little babies. They're adorable. And then if we go in for a lab, we can play with those as well. There are 3 insertion techniques for this. There's the tongue blade. So the tongue blade says, hey, you're just going to use that long popsicle stick thing. Move, put it into the oropharynx, put pressure on it going outward, right? Going this way. And then you're just going to insert it like its natural curvature, right? So you're just going to insert it naturally like that, so with its natural curvature. There is the 90-degree, I call it the fish hook. This is where you're going to turn this oral airway 90 degrees, and then you're going to insert it halfway into the oropharynx. So halfway into the oropharynx, and then you're going to rotate down when you're past that halfway mark, and that'll hook it behind the tongue. So you're sort of doing it 90 degrees until you're sort of past the tongue, and then you flip it down to the normal down position. And then there's the 180 degree. This was my preference as a practitioner, right? And we'll practice all these. I want you guys to practice all these. The 180 degree says we're going to actually insert this tip upside down. So instead of it doing it this way that you see here in the picture, I'm going to insert it backwards. So here's my tongue blade, and then it's actually going anterior. So I'm going to insert it halfway, and let's say this arrow is their tongue. I'm going to insert it halfway, and then once I'm sort of past the area of the tongue, then I'm going to turn it 180 degrees until it looks like this guy. And so that also hooks it behind the tongue, therefore keeping the tongue out of the way. So play with those techniques. Make sure you get comfortable with all 3 of them. You never know which one is going to work best in each situation. And having those options and having that skill developed will be a big feather in your cap. Okay, nasal airways, we already talked about these a little bit. Hey, guess what? We're talking about the turbinates again. What do you know? Anatomy and physiology. I'm a big nerd for anatomy and physiology. Okay, nasopharyngeal airways, or nasal trumpets, also known as. We want to make sure that you're using the right size, neonate through an adult, this little kid, because kids are adorable. So you're going to measure from the nair to the tragus, right, to that little tragus area there. And that's going to tell you sort of the right size to use. Don't use one that's too long because it can curl up into the oropharynx. It can block the airway, right? It can go too far and actually block the airway. You don't want to use one that's too short because then it's not going to keep the tongue off the back part of the oropharynx. So it's important that you use the right size. And now you know how to use the right size. So nair to tragus. So if it's too small, not going to be effective because the tongue's still going to fall in the back of the airway. If it's too big, can actually block the airway and cause trouble that way too. Make sure with these, usually they have a bevel on the edge of there. So most of them are actually meant to go on in the right side of the nair, your right side of the nair, so the patient's left side of the nair. And the bevel would go towards the septum. The opening of the bevel would go away from the septum, but the longer part of the bevel would be towards the septum. I hope that makes sense, and we could play with it together. Remember, I always put a little drop of saline or a little squish of saline in there just to sort of help water things down, and then lube up the nasal trumpet, especially if you have someone that has like chronic AFib and are on blood thinners, Make sure you put some lubrication on that nasal airway. It can really, especially if their nose is dry, really rip some tissue and cause a massive nosebleed. And that's not something you want to add to the current situation. And that's not something you want on your patient just in general. So make sure that you take your time, make sure you lubricate that airway, make sure you're doing the right technique, and make sure you go as low as possible, because we want it in the inferior part of the turbinate, like I talked about before. There's the most space there. And when you talk about nasal intubation, same thing, as low as possible if you ever have to be a part of one of those. Heavens to Betsy. And extubating a patient that's nasally intubated is not fun. I'll just tell you that now. But remember, go as low as possible, measure from the nair to the tragus, make sure you're using it, and then know why. Why are you measuring it? Why? And then you know how to troubleshoot it. If you're still not getting adequate ventilation, if you're still not getting adequate oxygenation, right? Guess what? The tongue is still blocking the airway. Maybe it's too small. Maybe get me one size bigger, right? Maybe there was an anatomical indifference on this patient. So you know if you're not getting good ventilation and the tongue is still posterior to the airway, you're not being able to push a breath in with your hand bagging, then you know that could be the issue. Get a size bigger. If the airway is just occluded, you cannot get it in, there's something blocking the airway, obstructing it, then you know you might have gone too big. So you know how to troubleshoot this already based upon knowing the right size. All right, this is the ultimate goal. Hey, get this obstructed airway, get rid of it, right? We're going to get rid of it by somehow stenting open the airway, whether it's the nasopharynx or the oropharynx, or we can even use a CPAP. I had a pediatric patient. She was about 14 or so, extubated, and her tongue was just, she was a neurological injury patient. She had a head trauma, and she would just sort of have that snoring, obstructive sleep apnea look to her when we extubated her. So instead of reintubating, I asked the physician what their thoughts were on trying CPAP for a little bit. So I just used a little bit of CPAP with her. She still wasn't conscious, right? She was sort of that neurological injury status, I should say. Her GCS, her neurological status was a little obtunded there, but she was still able to breathe and all that stuff on her own. So instead of reintubating her, just because of that, I asked, what if we tried a little CPAP and see if that starts coming around? And it worked perfect for her. We avoided reintubation, and she was able to neurologically come around relatively quickly after that, actually, too. So it was pretty neat to see something like that where I didn't even use something mechanical or a nasal trumpet. I just went ahead with doing positive airway pressure. So little things like that. I'm not saying to use that in every situation. You guys are going to have to work with the care team and look at each situation individually and decide what is best in that situation. So that's why I can't give you any flow chart of like start with this, start with this, start with that, right? I can give you, hey, if they're semi-conscious, nasal trumpet. If they're fully unconscious, oral airway, right? But you got to use your discretion here. You got to look at each situation, and that's where you become practitioners. All right, mouth-to-mouth resuscitation. This is just more for completeness. There are one-way valves and pocket masks. Just remember, here's the big thing with this, and the exhaled oxygen that you're giving the victim, if you are doing some form of mouth-to-mouth, is hypo. It's lower than room air because it's used oxygen. So your average exhaled oxygen level is about 16 to 17%. That's it. So you're actually giving them hypoxic gas therapy, right? And that's only if they have a congenital heart defect. And certain congenital heart defects do we want to do hypoxic gas therapy, but you just understand, when we're doing compressions, if the patient's airway, or the victim's airway, I guess in this scenario, if the victim's airway is patent and they're doing chest compressions, the chest wall is going in and then coming back and recoiling back up again, right? So that's actually causing negative thoracic pressure, which actually, if the airway is patent while they're doing compressions, that means that they're actually going to draw gas into their lungs with chest compressions, with the full recoil of the chest compression. So if they're going deep enough with the chest compression and they're recoiling fully, which is a common mistake is people don't recoil fully, then you're actually ventilating the patient as long as their airway is patent. So they might actually get a higher FiO2 with compressions only in a patent airway than if you're manually ventilating this patient. Just something to consider, okay? All right, lemon. This is a great airway management technique. This mnemonic is one of the ways that we can identify a difficult airway. So this is, we're going to look externally, and I'll go into on each of the following slides here. But L is for look externally. I want to see if there's anything abnormal that I can pick out right away. If there's burns, a knife stuck in the trachea, you know, all those things. Is there something, thick neck, a small neck, long neck, like different things like that. Then I'm going to look at the 3-3-2, which sort of tells me measurements of the airway. The Mallampati scale is something that's out there. I want you familiar with it. And that's actually an area on the adult critical care specialist exam for that credential as well. Talking about the Mallampati scale. Obstruction, anything that could block that, or even the neck mobility, especially when you're looking at it, head tilt, chin lift versus a moving their head around for proper intubation optimization. You're going to want to know these, so let's get into them. So L is for look externally. So if it looks hard, it probably is. If you have those patients with a really long neck, their airway might be hard to see, and you might have to use a longer size 4 blade, right? So their different bodies on adults can make it a little hard, especially when they have something like a long neck. Even though they might be a normal height, they might have some dimensions that are a little bit different, and that's okay. We just need to be prepared for that. So if we can't get the cord out of the way, we can't get a good view, you might have to upsize from a size 3 Mac to a size 4 Mac blade, right? So if you look at the patient and you see they have a really, really long neck, then you might want to actually go ahead and start with the longer blade, right? If they're obese, if you see they have a short neck, then that might be something where we might not want to start with the 4 blade. We might want to start with the 3 blade if their neck's really, really short. Also, if they're obese, that means there's a lot more pressure pushing the airway, occluding the airway, or make it harder to push the airway out of the, push the soft tissue out of the way to look at the airway. So we need to be aware we might need to do video intubation with someone that has obese or a really long neck. Short neck. Trauma, any trauma to the airway, we might want to do a direct visualization technique where we actually use one of the cameras, whether we use a bronchoscope and put the ET tube over the bronchoscope and intubate with it, or we might want to use a glide scope or CMAC or any of those other ones out there that are video intubations. We might need to use that, especially if the airway is bloody and traumatic. I had that kid that came in that was hit by a vehicle on his bicycle, and his airway was so traumatic. There was so much blood all over it. He was intubated by pre-hospital, and they wanted to check to make sure his tube was in the right place. And under direct laryngoscopy with just the blade and the handle, they couldn't see anything. It was just blood all over the place. So we had to use a bronchoscope to verify that we were in the trachea. And at that time, we didn't have like the bougies or anything like that. That was a long time ago. But look externally. If there's anything like this going on, it might indicate we might need different equipment, or they might have to make sure that we have the right people available for that intubation. The 3-3-2, this is where you're going to use your fingers, right? And we'll practice this in the lab. Just remember this, right? 3-finger width in the opening of the airway. So take 3 fingers on your left or right hand, and that's sort of you put them vertically in between your top and your bottom teeth, right? Is there at least a 3-finger width, right, to the opening of the airway? If there's only 2 or less room, that might be an issue with the jaw opening or the ability to open the airway, and we might have to do a video intubation, like with a bronchoscope or one of the other video intubation systems out there. So that one will help you determine if their airway can be opened enough to allow for intubation. The second 3 is from the tip of the jaw to where the neck starts, still vertically, right? And you can feel this on yourself right now. So if there is only 2 finger widths, then it tells you the airway is very anterior, and you might have trouble seeing this, so you might need to do a Selleck maneuver. You might need to position the patient's head differently. You might need to use a Miller blade, right? If there's 3 or more, it's going to be more of an anterior airway. So when we're looking at this, if there's less than 3, then it's going to be an anterior airway. If it's 3 or more, then we should be able to see the airway pretty easily. So that's where go ahead and use the Mac blade. So if you have at least 3, you should be good to see. I don't know. That's how I remembered it. If there's only 2, you might need something for a different view. And that's how like I said, I'm weird, and that's how I remembered it. I don't know if that helps any of you guys or not, but there's less than 3, you might need to change your blade. If there's 3 or more, you should be good. 2 is the floor of the mandible to the top of the thyroid membrane, and this tells you how long it is to get to the glottic opening. So if you have those patients with really long necks, that might be a 3, right? And that might be I need to get a Mac 4 instead of a Mac 3. Right, so make sure that you're looking at something like that 332. That might help you find some issues before you ever get started to make for the cleanest possible safe intubation ride. Malampati, I love this. This is just looking at how visible the airway is. So the lower the score, the more room you have. So you want a class 1 down here. You want a good open view. You want to be able to see structure, the uvula, the soft palate, the hard palate, all that stuff. If you can see all that stuff, that's great. That means we should have a good ability to view our structures for high visibility intubation. What would be bad is if their airway was swollen or their jaw wasn't able to mobilize, like they only had a 2 for the first part of the 332. If they only had a 2, if they had a 222. So if they had a 2 for that first part, it might be closer to that class 4. So if you have a low class, usually we're going to do short-acting intubation drugs that only take like 90 seconds, like succinylcholine, and this is where you're going to get into your rapid sequence intubation stuff. If you have a high number or high class, we might use longer acting paralytics or longer acting intubation drugs like sedation, paralytics, because it might be harder or take us longer to get that airway established, right? The last thing you want is the patient waking up in the middle of you intubating as far as their airway reflexes go and then vomit and cause aspiration, right? So alternate intubation equipment may need to be available, sometimes outside the room, sometimes in the room if they had a high class. And then we also just need to be aware some of these patients might need a surgical airway just to make sure that we have that available if needed, if we're going to attempt an intubation but we're unable to get it, especially if we're using long-acting paralytics. We might have to do a surgical airway like a bedside perc or a cric, but usually we just go for the perc because that was almost just as fast for a lot of our patients. All right, so this is where you're looking at this. So which one of these would be a class 1? Would it be this one on the left, this one on the right, or this one on the top, right? You tell me, right? This is where you guys are hopefully coming together with all this. Which one would be a class 2? Which one would be a class 4, right? So make sure that you're understanding the visibility. So if a physician says, hey, this patient's a class 4 Malampati, then you understand, okay, let me go get some video intubation stuff. Let me, right? Understand that what does that mean to you? So not only can you classify it, but I also want you to understand, what does it mean to me, right? What does it mean to me that they're Malampati's 4? What does it mean to me that they're Malampati's 1? I want you to understand what that means to you as far as your interventions and ultimately how you're preparing for this patient. This is just here for fun. I just love this Malampati class for sharks. You can look at that later. All right, lemon. So L was look externally. O was look for obstructions. Look, evaluate. Oh, sorry. E was for evaluate the 322. M was for Malampati. O is for obstructions, right? So this is where you're going to look for different things like hematomas, tumors, anything that's impaling someone, burns. I'm talking about airway burns, not C. Montgomery. But when we're looking at airway swelling, a burn victim, or any growths in the pharynx, anything like that can really make it hard for an intubator. If you're looking at babies, laryngeal webs, things like that can all be very difficult for a lot of babies or for a lot of adults when we're looking at these different types of situations. I had some babies with the arterial venous malformations, and we did a lot of those at our facility, and it would impede on their trachea and their ability to breathe. And eventually some of those we had to go ahead and put a tracheostomy tube in because that arterial venous malformation was just so big and blocking out the airway that to intubate, anesthesia was having a difficult time the bigger and bigger that venous malformation, arterial venous malformation got. So things like that can make it very difficult to establish an airway, so we might need to think alternative airways in that situation. So in my case where we had that baby that had the arterial venous malformation, I think she was like 18 months old or so, when we had to go intubate her during her stay, we had to go all the way to the left because the AVM was on her right. And so it's something that you need to be able to be aware of. If you do have to intubate or use an alternate airway, what does it mean to me? How will I modify my techniques to still establish an airway on a difficult patient? Neck mobility is going to be a big one here. Ideally, in a perfect situation for an adult, you always want to, and hopefully you see this line here, you always want to line up the opening of the ear with the sternum. You don't want this slanted situation. You don't want it below the sternum. You don't want it above the sternum. You want it even with the sternum. This is called aligning the TPO, the trachea, the pharynx, and the oropharynx. So make sure it is aligned. Make sure you don't have one of these slanted situations. This is from ASA. This is from anesthesia. Because these are lined up in this situation, right? This is the ideal situation here. Because the TPO is lined up, it allows you to get the best view of the vocal cords, the best view of the airway when you're intubating. If it's below, like you see in this top picture here, then it's going to make the airway be very anterior and make it harder to view the structures and harder to intubate. So if you are able to do something like roll a towel under their scapulas or roll a towel under their head, or like this, they have this special pillow here in the OR. If you're able to do something to line up the ear with the sternum, that will allow for the best possible view of intubation. It will make it so much easier, but you need to make sure that their neck, their C-spine, their everything there has the ability to do that before you start messing around, because that could cause serious other issues. So elevating the patient, if it's safe to do so, to line up their ear with the sternum is evidence-based. Do it. You will not regret it. Neither will the people you work with. It will be a lifesaver. Literally, it will be a lifesaver. You will be able to get so much more intubations lining up the ear with the sternum than you ever will with it out of line. Ideally, if we could practice with the C-collar on our mannequins, we should. But yeah, just make sure that ear is in line with the sternum. All right, let's talk about different tubes. The combi tube's not used as frequently anymore, but still something that you might see somewhere in different regions of the world or in the US maybe. Primarily used by pre-hospital providers. It's meant for a blind intubation. In other words, we stick it into the airway, and it can either go into the trachea or into the esophagus, and that's okay either way. So this is a double lumen tube. It's not the double lumen ET tube, but it's a double lumen tube, so there's two of them. And it has an esophageal obturator airway and an endotracheal part to it. So it's for blind insertion. In other words, we don't have to see the vocal cords. You just stick it in there and then you start ventilating. Here's the thing with this one. There's two things. You have to use a 100 ml syringe for the esophageal obturator part, this guy right here or right there. or you use the 12 ml syringe, which would be for the cuff part, the trachea or esophageal cuff. So if the tip of the tube goes into the esophagus and you inflate that tip and you inflate the esophageal part, that means all the gas is going to go out of these little holes into the lungs, and your patient is ventilating. And traditionally, if the patient's positioned poorly or left to its own devices, you're probably going to get it into the esophagus if you're not intentional. Very rare people accidentally get it into the trachea, but it could happen. It's meant to be, if both of these are inflated, all that gas is meant to come out of these little holes there, and we have one of these in our lab as well. And so it's meant to ventilate there by blocking the esophagus and blocking the oropharynx, and therefore gas pressure will go into the trachea and into the lungs. Not a permanent solution. So if we ventilate and there's no chest rise, you're going to switch over to the other one. This one's not used as much anymore, and then there is, I believe, a YouTube link that you'll have to watch in the other in the regular presentation on this. And I think this is the link here that you're looking at. So you're going to insert into the mouth with a jaw lift. You're going to inflate both of the cuffs when you do it. You're going to bag through the blue one first. Listen to the stomach. If the lung sounds are good and you don't have gastric sounds when you're listening, then you continue to use what you're using because it's not going to the stomach, right? And this means that it's placed into the esophagus, right? You occluded the esophagus, you occlude the oropharynx, and all the gas is going out of those little holes. If the lung sounds are negative, switch to the other tube, all right? And that means you accidentally got into the trachea. Hey, there you go. And you're going to switch to the other tube, and then you're going to be able to ventilate that way as well. So make sure you watch that video. Pretty good video overall. The king tube, I'm a big fan of the king tube. Just make sure you use the right side. This seals off the esophagus and the oropharynx. Sounds a lot like the combi tube, but it's designed to specifically go into the esophagus. You purposely put it in the wrong place. You purposely put it in the esophagus, okay? All our RTs were trained to put it in the trachea, right? This one you purposely put in the esophagus, right? Watch out here, especially with the combi tube and the king tube, and even LMAs, you got to be a little careful of this. If they have varices, esophageal varices, you could cause bleeding and trauma and intubation. With varices, you need to make sure you put it in the trachea. You can't open those varices and cause bleeding and all that bad stuff. So just be careful with these. If someone has varices, this is going to be a risk versus benefit situation. But the king tube in general, purposely put into the esophagus, and then just like the combi tube, you inflate one balloon this time, which is great. You inflate one cuff, you inflate one area, and it actually inflates both the oral and the esophageal cuff at the same time. So you have to use a large volume syringe. So large volume syringe for this guy. Single inflation port is what I was trying to say down here, right? Single inflation port instead of having to do two separate ones like you had with the combi tube. Needs to be in the esophagus, and you just use the jaw displacement, put it in the esophagus, and there's ventilation holes right here where it's going to block the esophagus, block the oropharynx, therefore all the gas will go hopefully into and out of the lungs. The cool thing about this is we can actually put a bougie, and that's why you see this blue tube here. It's called a bougie. And we can actually put it through there, and we know we're going into the trachea because we're blocking the esophagus with that balloon, all right? And so we can put the bougie in through that ventilation opening and leave it in the trachea, and then pull the king tube out, deflate the cuffs, right? Pull the king tube out once the cuffs are deflated while we leave the bougie in place, and therefore we can then intubate or put the ET tube over the bougie, and we're in the trachea. So we can use pretty much the bougie as a guide to help us do a blind intubation as well. Love the king tube, purposely put in the esophagus, as long as the patient doesn't have anything that would cause any risks. I think it's a great option for people that do not have a lot of intubation training. right? 2 insertion techniques for this: the jaw displacement, where you fishhook the tongue, or the oral airway, right? Slide the oral airway over, and then you can sort of see it. Make sure it goes all the way in. Use a large volume syringe. You can't use your 10 ml syringe here. Large volume syringe. You might have an issue if you put it, if you don't put it in the right place. If you put it into the airway somehow, and instead of the esophagus, you're not going to be able to ventilate very easily. Or if you push the tongue down, if you push the tongue against the glottic opening, the tongue sort of got pushed out of the way, you didn't move it out of the way enough, that could also be another issue. So you need to be able to troubleshoot these as well. Please watch that video. When we're looking at this, when we have the king tube in place, it can be a great temporary airway. We can ventilate a patient, we can stabilize a patient with a combi tube or a king airway until we place a more permanent airway like an endotracheal tube, or go for a tracheostomy. Depending on the scenario, it's important that we understand you can ventilate, you can help stabilize a patient with these alternate airways. They're not permanent. They're not something you'd want to leave in for a week or even 24, 48 hours usually. Ideally, we would take them to surgery and get a surgical airway. We would do something else, but they're a great temporary thing that we can use to stabilize the patient until we can have them stable enough for a switch over or to take off altogether. In LMA, these are very common. Most commonly used for surgeries under 2 hours in the operating room. In fact, a lot of our paramedics did a rotation in the operating room to help with their intubation skills, and a lot of them did not get their intubations because they were using mostly LMAs. LMAs are great, especially something called a fast track LMA. This one here. This is an intubation LMA. So this one, purposely, the tip will go into and occlude the esophagus, and all the gas then comes out of these little ports and goes into the trachea. So this whole thing seals off the oropharynx up here, and this tip seals off the esophagus. So just like what we were talking about with the other tube, same concept. We're sealing off the oropharynx and we're sealing off the esophagus. So therefore, all the gas that's coming out of this will go into the trachea. These are very great, very useful. You can ventilate very well off of these if they're placed well. So this is all, once again, you using your technique, you're developing your skill with these. In fact, we've had to use these for difficult intubations. See how drastic this hook is here? For someone that has a very anterior airway, we can actually put this ET tube through here, and then a fast track LMA puts it anterior, and hopefully the ET tube will go through the trachea. We take the hub off the ET tube. So we take this little 15mm hub off the ET tube, and we slide the ET tube through the LMA, and then we take the LMA out while the ET tube's still in there. Then we put the hub back on the ET tube, and we should be in the airway. So we've had to do this a couple times for very difficult airways where we needed an endotracheal tube where the LMA wasn't quite enough. So just understand these options are also available and be able to use them. There's a video on it I have here as well. Make sure you go and watch those videos. Right, this one placed into the entrance of the esophagus. Short surgeries. There's special ones called the fast track. I love these. Can be used to intubate. Some of these are reusable, so you have to get them sterilely processed. And then there's special ET tubes, like I said, that go with them as well. I've had physicians that use the regular disposable single patient use ET tubes as well. However, these have a special flexible ET tubes that can also be used. So make sure that you know your hospital's policy and procedure on these, right, before you start using them. So these are things during orientation and during clinical rotation. Hey, these are good to ask. Hey, what's your policy on this? Or do you guys use an LMA? Or do you guys use king tubes? Or do you have all of the above, right? I know we had like all of the above type situation. So make sure you know how to use them. Make sure you know that policy and procedure that they have for them as well. Sometimes, if we have the inability to get a surgical airway fast, we might have to do a cricothyrotomy, especially if their upper airway is unavailable. So when we're looking at this, you might see some crazy things where you cannot ventilate, you cannot bag mask that previous patient. You're going to have a hard time ventilating, and it may not be we have enough time to put in a tracheostomy, a bedside percutaneous tracheostomy tube. So we might have to do a cricothyrotomy. So cricothyrotomy is when all else fails. So this is usually not a first option. This is one you see in the movies where they empty out a pen and then they put the pen in there. Don't do that. When they're doing this, this is sort of a very, very, very temporary tracheotomy. Very temporary. Surgical procedure, they're just going to poke through between the cricoid and thyroid membrane. Like I said, you were feeling that before on yourself. You can feel it again right now. They're going to poke through, and then they're going to put this sort of, pretty much this IV part there. Now, there's special parts they make for this, but they're going to poke through. Here they have the little scalpel and everything. Poke through, and then we're going to put this sort of temporary airway in and allow for some ventilation. So this is what you're looking at here. This is a cric spike, right? And this is just an IV drip chamber. And then it's cut and then inserted into a 15 millimeter adapter, right? Isn't that crazy? They do make one specific for this that I'm aware of. I don't know how common those are out there. In my practice, I never had to deal with one of these. We were always either able to do a surgical trach, use a fast track, right? Do one of the alternate airways we already talked about. So I'm not as familiar with this as maybe some others are, but this is how they would do it, and you'd hook it up to the ventilator and you could still ventilate. Now you just got to understand the lumen, because of Posey's law, smaller lumen or smaller radius, I should say, if we're talking about Posey's law, that radius is going to mean you have high peak airway pressures. You're going to have a harder time getting gas to go in and a harder time to get gas to go out. But at least you're getting some gas going in and some gas going out. It's some way to ventilate and oxygenate the patient. I hope that makes sense. So you can bag, you can ventilate, oxygenate. Just understand it's going to still be difficult. All right, it's not going to be perfect, smooth sailing once this is in. You still have a difficult road to ventilate and oxygenate a patient with such a small airway, and hopefully that stabilizes them enough to where you could put in a tracheostomy, a perc trach or an open trach, but perc trachs are done faster usually. Okay, we finally made it to the endotracheal tube. These are usually PVC or silicone. This sort of just depends on what iteration or what materials they're using nowadays. Most common short-term artificial airway overall, still an endotracheal tube. We have ranges from a 2 to a 10 for humans. There's even bigger sizes for horses and things like that. And we still have a horse ET tube somewhere in our lab. I think it's pretty fun. I don't know if it's used or not, but 2.0s for super tiny babies. We never use those because you can't suction through them. And if there's a tiny mucus plug, it will really clog it up, makes it hard to ventilate and oxygenate those babies. So usually a baby, we never go less than 2.5, but 2.0 all the way through 10. Most adult intubation box goes up to like 8.5. It's very rare you'll see an adult intubation box that has like a 9, 9.5, and a 10, but they could exist out there. Most of these are cuffed. The baby ones, right, from a 2.0 to a 4.0 might be uncuffed, and then we might have like a 3.5 through 8.5 cuffed. For this. And so we have a baby intubation box and adult intubation box, and I'll let you guys sort of play with those as we go into the lab as well and stock those. And this is what you're looking at. This one has that stylet in place. That stylet is that metal tube that's inserted here, and it gives it sort of that rigidity, it gives it that structure. So when we go to intubate, we can still go anterior, we can still make sure we have all the structures available. The pilot balloon, this is a little thing on the edge of it, and hopefully you guys talked about this already in a little bit in therapeutics. The pilot balloon is an indicator of the cuff status. If it's ruptured, if for some reason they cut it off, or you cut it off, unfortunately, you can repair without exchanging the tubes. There's cuff repair kits and things like that. So you can use a torn cuff or ruptured cuff can cause the cuff to deflate. Not always. I've seen some anesthesiologists, and I'm not saying names, but I've seen some anesthesiologists cut the pilot balloon off and then think that the cuff is now deflated and then start ripping it out of the patient to extubate. I'm like, oh heavens. That's why your patient has severe sore throat at the end of it. Or stridor. Why are they stridors? Oh yeah, you just cut it and pulled it. Yeah, that's just get a syringe and pull the air out of it, and then you know it's good. Anyway, we attach the pressure monitor to look at the cuff pressure, and we'll talk about cuff pressure later on. Hopefully you'll see it in your book as you read through the materials as well. Cuff pressure is going to be a big one to monitor. To make sure that they're not getting bacteria and stuff that's culturing the back of their mouth while they have an artificial airway from going into their lungs and causing a higher chance for a development of an infection or pneumonia. And also we want to make sure it's not overpressured to cause impeding of venous blood flow and therefore could cause necrosis or tissue damage if it's overinflated. So we need to make sure it's correctly inflated. And even there's ventilators now. I know of Hamilton ventilators where you hook up the cuff of the artificial airway to the ventilator and it automatically inflates and deflates and all that stuff. So it automatically measures it and it actually adjusts it. It's pretty cool. The Murphy's eye, this is very important. This little opening here, it's located below the cuff and it allows for collateral ventilation. So if there's something occluding the tip of the ET tube, like a mucus plug that's occluding the tip there, we're still able to ventilate the patient. Now, obviously, our peak pressures, we're going to know because the ventilator will say some certain things are going on and you're not going to be able to pass the suction catheter. So that's where we would go ahead and just probably still understand they're ventilating, but then we're going to work the problem, figure out what's down there. Do we need to get a bronchoscope, go and fish it out, so on and so forth. So this is a safety feature, having this extra opening there, that Murphy's eye. It's just an alternate route in case the main route is plugged off. It is a lifesaver in every aspect. Okay. So the radio-opaque line, this is perfect. We want a radio-opaque line. This is something we see on intubation. After we get an intubation, we want to get an x-ray to verify placement, hopefully about 1 to 3 centimeters above the carina. So when we see it, that radiopaque line helps us see on x-ray how far above the carina we are. We don't want it too high because then we know we're up against the vocal cords. We don't want it too low because then we know we're not probably going to be inflating the right upper lobe, or we could be tickling the carina and causing vagal issues like blood pressure and heart rate dropping, things like that, and then as well as inappropriate ventilation of the right lung. So, or the left lung if it's too low too, could be closer to a main stem. So that radiopaque line is going to be very helpful to us. The Murphy eye, of course, you already talked about that, where you have collateral ventilation, and then the bevel tip, the left-facing bevel tip. The bevel here is designed to help us go through the airway, a very tight airway, atraumatically or without trauma. Okay, so if we have a very narrow portion, we're going to put the very small part of it here against that area that's already open, and then we can use that as a opening point to insert the rest of the ET tube with a lot less trauma compared to ET tube that has no bevel. So no bevel, problem. Bevel can be helpful, right? So we're going to put that in there. Less likely to be occluded by secretions as well if it's beveled. So there's a lot of advantages here. I don't know of many tubes out there that aren't beveled. Now, however, I've seen non-beveled ET tubes be those non-disposable, reusable ones for those fast track LMAs. I've seen them like this where they have no bevel. So that's a whole separate situation, of course. ET tubes, you have two markings. You have the inner diameter marker. You have the centimeter markings. So this would be the inner diameter up here. So we're looking at this 7.0, and this one is a 7.5, and then this inner diameter is an 8.0, right? Or a 6.5. You're gonna have your centimeters marking, and so the centimeters marking is this one here. So 18 centimeters, 17, 16, 16, right? So that's how deep it is, and we're gonna look at this centimeter marking to the teeth or gum, depending on the patient. So your your chronologically advanced individuals might not have teeth, so you might have to use their gum line. Same thing with your newer, younger neonate patients, obviously not going to have teeth if they were born 6 seconds ago, so you might have to use their gum line as well. So if they're 18 centimeters at the gum, 16 centimeters at the gum, we always use gum or teeth. We do not use lip because lips are soft tissue, they swell, all that bad stuff. So use gum or teeth. The radiopaque line, we already talked about that in the purpose there. All the ET tubes universally have a 15 millimeter connection. Standard for all resuscitation equipment. So if you put anything that's 22 onto it, it'll connect. So 22 attaches to the 15. So that way it's universal. You know it's going to work. That universal 15 millimeter connector, no matter if it's a 2.0 ET tube for neonate or a 10.0 ET tube for Shaquille O'Neal or whoever, right? It's going to be that same 15 millimeter adapter. It's a standard, right? So these are the centimeter markings just in more detail. Right, if you want to look at these as well, right? Centimeter markings, and that's what you're going to look at. They're 24 centimeters at the teeth. That means that this 24 is aligned with their teeth or their gum, and that's how we sort of know how deep the tube is inserted. All right, high-low evac tubes. We use these a lot at the facility I worked at. The advantage is going to have an extra little suction port there, and you'll see it here that's yellow, and I think we might have some of these in our lab too. And that helps, and it's above the vocal cords, right? And it just suctions a bunch of secretions that sort of pool in the back of the patient's mouth. It helps sort of suction those secretions. We either set it for intermittent or very low suction pressure that's continuous. So continuous at 40 millimeters of mercury or intermittent at 120 millimeters of mercury. And that just suctions out some of those like little things that culture in the back of their mouth, right? To help prevent that from going to their trachea and causing an acquired condition, ventilator-acquired condition like a pneumonia or anything like that. The only issue, and some people may not like it, and that's why I'm just exposing you to, A, what is it, and then what's sort of the controversy here. The controversy would be that the outer lumen is a little bit larger than your traditional ET tube, and so if you have someone with a tight airway, the anesthesia or whoever's doing this doing this difficult intubation might want a more traditional tube, and that's just, you know, preference, right? Because the outer lumen is larger, because it has that suction port, that's what you're looking at there. Parker Flex tips, I love these things. We eventually had to get rid of them, but I loved them because they were just expensive. Parker Flex tips, they also come in a nasal airway as well as ET tubes, and you see how that bevel is also curved. You see that curve of that bevel there, right? You see how it's curved. See, it's curved over. And the beautiful part about this is if you have a patient that has very tight vocal cords or nasal turbinates, it helps that point come more towards the center part of the lumen of that tube, and therefore it's a lot less likely for that tube to get caught up on any of the airway features. In other words, it's less traumatic for someone that has a very tight nasal or endotracheal airway. Right? So the next slide here. So this is what you're seeing here, because that it goes into the very center part of the lumen there. The idea here, and you can see it here on the bronchoscope, how it just hugs the bronchoscope compared to your normal bevel on the right there. Its ability to go through a tight space is a lot more efficient just with its design. So if you hear someone talk about a Parker Flex tip or what's the advantage of a Parker Flex tip, there you go. And so these are things that just different things that you might see out there. So I'm just trying to expose you to different things, but this is great because it does help reduce the sort of possible trauma that procedure could cause. Cuffless endotracheal tubes. The NICU is going to be your primary place here because what's the smallest part? The glottis, right? It's going to be that glottis, right? When you're looking at this. Avoids tracheal damage, need to change for a bigger tube if the leak is too big. So if a baby grows while they're on the ventilator, we might have to upsize, half size up their endotracheal tube if they start leaking on the ventilator, because now they're bigger, right? Their trachea is bigger. They're glottis, their cricoid cartilage is bigger, right? So when we're looking at that, that's going to be the bigger part of it. Make sure you use the right size for the right size baby, and we're going to talk about that more in perinatology, right? That's where we're getting to it. We'll even go over NRP and all that stuff there. A lot of times these kids, and understand this, even if you never work NICU in your whole life, but you somehow have to get called to a situation where they intubate a baby and they're going to ship it to a children's hospital of some sort or another, understand that that tube has a higher chance of accidental extubation because there's nothing sort of keeping it below the vocal cords, right? There's no cuff to keep it below the vocal cords as a sort of extra safety feature as well. So if there's too much torsion on the ventilator circuits, there's too much torsion on these 15mm adapters, if something pulls or on the circuit or the tube, that tube could easily be extubated, easily. So just be very cautious with this situation. Ray tubes. Ray tubes are awesome because they allow us to sort of ventilate patients that have jaw issues, and they're mostly used in surgery and stuff like that. So that's going to be the primary place. So if someone asks for a ray tube, odds are the OR has it. These are very difficult to suction because you see how much curvature there is here. They're great for oral and nasal. Used for burn victims, trauma victims, broken facial bones, especially securing an airway or if someone's jaw is damaged or blown off or anything like that. These are just a different way to make sure the patient is still getting ventilated overall. So you can either put it through the nose like you see with this little kid here, or you can go oral like you see up here with that patient. So it can go through the nose or through the oral pharynx. And it can be very helpful for patients that need a jaw surgery or things like that. Double lumen ET tubes, DLETs. These are great for a single lung ventilation or independent lung ventilation. So let's say you had a patient that had a necrotizing pneumonia on their right side. Do you want the right side necrotizing pneumonia to be spread to the left side? Well, that might be an indication if the care team deems it to go ahead and switch the patient to a single or independent lung ventilation where we sort of close off the right lung from the left lung. So we actually ventilate the lungs differently. And it's a 60-40 split traditionally. So the right lung would get 60%. If you had a tidal volume, let's say your tidal volume was like 500 mLs, right? And we're going to ventilate the right lung independently. We're going to use 60% of that tidal volume for the right lung. And then we're going to use 40% of that tidal volume for the left lung. Now, different hospitals have different policies. This is just me being general with it. So that's sort of how you would split it up, because remember, the right lung's bigger, has more lobes, has 10 segments compared to 8 segments. It has 3 lobes compared to 2 lobes, and there's no heart in the right side. The heart's on the left side. So that's why you have sort of that uneven split. That's why it's not a 50-50 split traditionally. However, your hospital's policies may be different. When we're looking at this, if we want to ventilate lungs independently, that's sort of how you do it. Used for surgery, especially, they might deflate that left lung overall. Let's say they're doing a heart surgery, an open heart surgery, and they want to deflate the left lung but keep the right lung going. Or a thoracic surgery and they want to deflate one lung and keep the other lung going, then they would just close off or clamp off one of these sides and let it deflate, or just open up one of these valves and let it deflate, and then the ventilation would just go to the other side, and it would be pretty easy to close it off, and then they can do their surgery without the lungs inflating and deflating, and then reopen it when they're ready to ventilate both lungs again after they're done with their surgery. So they use it primarily for surgery. The left-sided is more common. And you can use a left-sided double lumen ET tube for the left or the right lung. And we'll play with this in our lab, hopefully. You just got to remind me too. But the left side is the most common one. You do need 2 ventilators or an adapter if you want to use a bag this patient, right? So we can ventilate both lungs at the same time if we want to, or we can clamp off one of these and then ventilate the other one. So we have the adapter as well. But this is going to be great for patients who post-lung transplant, and we don't want to give that one lung a big tidal volume. We want to give it a small tidal volume to avoid busting sutures or trauma. Then we might need to do a double lumen ET tube on that patient and ventilate one lung gently. I had a patient stomped on by a horse, I think. Yeah, it was a horse or a bull. Emaciated one side of their chest, and the lungs were just shredded. And so they did the double lumen ventilation. We did independent ventilation, and one lung was placed on very gentle ventilator settings. The other one was placed on its 40% settings, and then we were able to sort of stabilize them and let that one lung sort of heal. Still have some ventilation, still have some oxygenation, but let it heal and use the other lung normally. So very difficult. We'll talk about this more when we get into the lab, but double lumen ET tubes, usually you have to use a bronchoscope to intubate, and I think I have some videos of that too. Self-inflation bags, these are most common on your adults. These are pretty universal. You'll see this almost every emergency department too. These are used with a mask for non-invasive ventilation. Make sure you're using the right side mask. We can also use them with the artificial airway. So right after we intubate, we can connect, you just take off the mask, and then there's a 22 millimeter adapter there, and you just bag the patient. 22 fits on the 15, which is the endotracheal tube, and then you ventilate that way. You do not need a gas source to use a self-inflating resuscitation bag. Once again, you do not need a gas source to use one of these. So if there's no oxygen in the room for some reason, or if you have to do this outside the hospital, or whatever, you have to evacuate, you could still bag the patient. It would just be on room air. All right, so you don't need a gas source. It self-inflates. The big thing here is it cannot provide continuous airway pressure, right? So if I squeeze the bag, gas will go into their body, right? Whether they're non-invasive or invasively ventilated, and then it will close this little like duckbill thing that's in there, so it won't allow it to give continuous pressure. So when we're doing this, understand if we need to CPAP a patient, or if we need to provide CPAP, we cannot use a self-inflation bag. We have to use a flow inflation bag if we want to provide CPAP. And flow inflation bags also give a specific FiO2 if we hook it up to a blender. And we can also feel lung compliance. There's a lot of advantages to flow inflation bags, but self-inflation bags cannot provide continuous airway pressure. We can put a PEEP valve or a little valve at the end of these, and what that does is that keeps pressure in there after we've done squeeze the bag. It just lets the air out when the gas is coming back out of the patient. It just lets it out with resistance. So it's like a PEP device. Positive expiratory pressure device, but it does not provide continuous positive airway pressure, right? And that's why with little babies, you might see us use a flow inflation bag a lot, because it can provide CPAP, but self-inflations cannot provide CPAP. So we can use a PEEP valve, not the same. It's just providing positive and expiratory pressure, not continuous pressure, but positive and expiratory pressure. The big thing here, if the patient does somehow experience some vomit, you might have an issue with, you might have to change the bag. Suction every time. You want suction available. Running, good yank hour is a lifesaver as well. Flow inflation bags, of course, I just told you, great advantages. Here's a disadvantage: you have to have a gas source, and it needs to be at the right level, right? So little babies, will run this 8 to 10 liters a minute. Smaller babies, like our micropreemies, might run it at like 6 or 7. This provides CPAP. We can give CPAP. We don't have to squeeze it, and it's going to continually give continuous airway pressure. It also does specific FiO2s. We just hook it up to a blender and we tell it 30% FiO2 or 0.30, and it gives 0.30. right? So it has that. We could also feel their lung compliance, or how hard it is to bag, or how easy it is to bag. We could also feel that compliance factor as well. Most of them come with a little pressure manometer. That's this thing here. And it will rise and fall. So we know that we're giving this baby 20 centimeters of pressure for the breath, and 5 centimeters of CPAP. So it would be 20 over 5. So our IPAP would be 20 and our EPAP would be 5, right? Pretty cool. So we have that feature that comes with most of them. Here's one of the other things with this. The technique can be tricky. If you squeeze it too hard, you might need to wait for the bag to fill up again before you can deliver the next breath, right? It's not a self-inflating, it's a flow-inflating. If you squeeze it too little, you might deliver too small of a breath. So your technique and your skill has to be good with this, and I want you guys to practice with this in the lab. Make sure you write a note to yourself. Make sure to practice these things, right? Make a little list. I want you guys to make a list. Things I want to practice in lab. Skills I want to develop in lab, right? And this should be on there. Flow inflation bags should be on there, especially with oral airways, nasal airways, flow inflation bags, right? And self-inflation bags. Make sure all those are on there. Troubleshooting, this is going to be a big help. Anybody that has an artificial airway, we usually use the DOPE mnemonic. DOPE is dislodgement, obstruction, pneumothorax, and equipment. So if you walk into a patient's room and they have a trach, or they have an endotracheal tube, right? They're intubated, or they're just trached and they're on a ventilator, or they're just trached in general. This is going to be your mnemonic that makes you look like a genius and makes you act fast, right? This is awesome. So D is dislodgement. The first thing you're going to look at is the trach still in the right place? Or is the ET tube shifted position, if it's an ET tube, right? Did the ET tube go in deeper? Did the ET tube come out? That's where you're going to look at the teeth or the gum line and see, hey, if they're supposed to be at 24 at the teeth and now they're at 19 at the teeth, they're probably extubated, right? Or if they're at 24 at the teeth, you look and you see it's 29 and almost at the hub, they might have been main stemmed. It says streamed, but main stemmed. Yeah. So the ET tube might be stuck in the right side of their lungs right now. Their right main stem. So that's going to be your first thing. Hey, is it dislodged? If their tracheostomy tube, did it come out a little bit? Do you see it sort of curved out of their neck a little bit? That's one of the big things you're going to be looking at here. Has the tube shifted position? So that's number one. First thing, check dislodgement. Next thing, is it tube obstructive, right? Is the tube kinked? Are they biting on the tube, right? Is tissue obstructing it? Something like that going on, right? Is there a giant mucus plug? So pass the suction catheter. If you're able to pass the suction catheter all the way through, then you know it's not kinking, biting, or tissue or anything like that that's blocking it. So you know obstruction is not a part. But if you're unable to pass the suction catheter, then you know it could be blocked by secretions. It could be a kink in the tube, which hopefully should be visible. They could be biting on it, or there could be tissue that's occluding it on the very tip of it as well. Right, so then you know something like that. Also, an obstruction, you could have a herniated cuff. So if the patient moves around, so here's the cuff of the tube, right, and here's the tip of the tube. Here's the big long part of the tube right there. So let's say the patient moves, the cuff can actually herniate over the edge of it and actually be occluding the end of it here down there as well. So that's where you would just suction the oropharynx, deflate the cuff, and then reinflate, and that should take care of that cuff sort of rolling down and covering the entrance of the Murphy's eye and the regular ET tube. So obstruction, the next thing you look at is obstruction. Can I pass a suction catheter? If I cannot, then my issue is something obstructing the artificial airway. P is pneumothorax. This is where you're going to listen. All right, did they have a central line insertion, especially subclavian, right? Were they coughing? Do they have blebs on their x-ray, right? Do they have emphysema? Do they have very low blood pressure? Do they have very high vent pressures? Do you see signs of subcutaneous emphysema or those little air pockets, especially going into their neck and their face? If those are things that you see, they could have a pneumothorax. This is where you do your chest percussion, right? Your diagnostic chest percussion. This is where you're looking at your high peak and plateau pressures on your ventilator. Really, really high pressures. So pneumothorax would be your next one. Then your final one, if you've gone through all these, the tube's in place, there's no obstruction, you've ruled out a pneumothorax with like a chest x-ray and your skills, then finally take them off that piece of equipment. That ventilator might be malfunctioning, right? So disconnect and use the backup ventilator, which is the handbag, right? The self-resuscitating bag or the flow inflating bag, whatever they have over there, use that and then work from the patient to the machine. Notice you work from the patient first back to the machine. So you look at their ET tube, look at their hub, look at the circuit, the suction part of their circuit, look at the dead space of the circuit, look at their inspiratory limb, look at their expiratory limb. Work your way back to the machine. Okay, and you always start at the patient first and work your way back. I had a situation where the NICU called me, and I went up there to the NICU, and they're like, the ventilator's alarming, and it's saying low pressure, and we think the ventilator's broken. So I did my dope mnemonic. It wasn't dislodged, it wasn't obstructed, the baby didn't have a pneumo, and I had the equipment. So I started the baby, and it worked my way back, and sure enough, they left the little port open on the suction ballard. They left that little port open, and it was just losing pressure through that little port, that little saline port there. And so I just closed it and fixed the issue. And I imagine if I went and got a whole different ventilator and did all this other stuff, no, I didn't need to, because I followed my steps and I started at the patient and I worked my way back, and sure enough, I didn't have to go back very far. Right? So just something little like that. So this is a technique. You will look like a genius. Follow your dope mnemonic. It is great for all artificial airways, neonate through adult. Do not forget this one. This one, you will thank me later. Trust me. All right, so dislodgement. This is where we talked about this, where this is the radiopaque line. These are our little kids. But you see how that's above the clavicles? The clavicle is technically called the thoracic inlet, right? And we talked about that a little bit before. But that ET tube is superior to the clavicles. That means that this baby is actually extubated on this picture, right? And over here, you see how the tip of the ET tube, that radiopaque line here, that tip of the ET tube is very, very far and actually goes to the right main stem. And look, one of the signs that you see when it's a main stem is that right upper lobe is actually bypassed and collapsed as well. Not only that, but when it's right main stem, that left lung, not getting a lot of ventilation either. So that's a classic, hey, I'm right main stem sign. So dislodgement is the artificial airway in the right place. Obstruction, is there some giant mucus plug in there? Is it kinked, especially neonates, or are they biting? And there's different types of bite blocks out there that prevents a patient's teeth from biting down and causing that obstruction as well. Can I pass a suction catheter? Pneumothorax. Hopefully you were able to pick up on this on the bedside. Make sure you got good skills. You have the heart sounds move over. The PMI, usually the blood pressure will go down with the tension pneumothorax. Your heart rate will skyrocket. You'll see a lot of physiological stress on this patient. And this is the only time on a ventilator I've actually seen it where another therapist used that diagnostic percussion. It was that drum sound. It was a classic drum sound. Now we can use other equipment like bedside chest x-ray. We can use bedside ultrasound, other things as well to look at this. And finally, equipment. Equipment can fail. They're just machines, right? Every once in a while, equipment can fail. And like I gave you that scenario about the baby in the NICU where it was just that little port that was left open. You just got to be aware of those situations, and hopefully you just take them off and ventilate them by hand and then change out the machine, right? Or have someone come and bring you a different ventilator and change out the machine. But remember, with this situation, always start at the patient and then work your way back to the ventilator. So always start at the ET tube or the tracheostomy tube and work your way back once you've worked out. So always follow it. Dope, dislodgement, obstruction, pneumothorax, equipment. You will thank me later for this.